All right, I'm Tim Henry from Christ Hospital, and my fellow moderator is Dr. George Dangas, who is from New York City and currently the SCI president. So welcome, Mr. President.
Great, thanks for kicking off this great session, Tim. We have a distinguished set of panelists.
So we're going to change it a little bit. This is altering up the thing where now we have a series of talk, and we're going to try to make sure that we have time for discussion because there are some really key topics. So we're going to start with Dr. Usman Babar from Oklahoma. Is going to talk about antiplatelet treatment for PCI with the state of the art. So Usman.
Okay, so thank you so much for the invitation. It's an honor to be here. And in the allotted time of about 10 minutes, what I'm going to do is try to highlight some of the salient and evolving issues around really dual antiplatelet therapy, particular emphasis on issues around bleeding reduction. So these are my disclosures. So just to take kind of a big picture overview, if we think about the field of DEPT over the last, let's say, 30 years, we've kind of gone through three, I would say, distinct phases. Late 90s, early 2000s, the focus was principally on how do we mitigate near-term thrombosis, particularly stent thrombosis. Kind of in the early 2000s, we began to realize that bleeding is an important event, has a significant prognostic impact. And I would say the current era is characterized by one wherein our focus is both on lowering bleeding, but also not paying a penalty on the ischemic side. So sort of a net benefit is how our thinking has evolved. So if we kind of use that as a context, if we kind of think about, why is it that we even need to give any kind of antithrombotic agents after PCI or ACS, it's really for two reasons that we all know. The first on the left is the issue, of course, of stent thrombosis, a focal event, typically occurs early after PCI. Certainly this has become rare, but when it does occur, still confers significant morbidity and mortality. And on the right-hand panel, we also need to give antithrombotic therapy to prevent later systemic atherothrombotic events that typically accrue from non-culprit culprit lesions over time. So how do we go about doing this? Well, several key trials, again, late 90s, early 2000s, were investigating different strategies. You can see here the STARS trial looked at aspirin alone, aspirin plus an anticoagulant, or aspirin plus a second inhibitor of the platelet. In this study was ticlopidine. And it was clear that the winner was dual antiplatelet therapy. And we also learned that the paradigm was we have a foundation of aspirin to which we then stack therapies on top of. And this is where DEPT is really born and comes into clinical practice and guidelines. And then we rapidly extend this to patients presenting with an acute coronary syndrome in the CURE trial in 2001, where we learn that these patients realize a benefit out to a year with dual antiplatelet therapy, and this is still why we give DAPT for 1 year in patients with an ACS. We then learned that we can add more potent P2Y12 inhibitors, namely prasugrel and triton-TIMI 38 is better than clopidogrel. And then, of course, analogously, the Plato trial taught us that ticagrelor is superior to clopidogrel, now in ACS patients who are treated medically, who undergo CABG or PCI. So these seminal landmark observations in late 90s, early 2000s form the basis for current clinical practice guidelines that tell us in ACS patients, irrespective of how they're managed, we want to give 1 year of dual antiplatelet therapy. We want to preferentially use the more potent P2Y12 inhibitors. And if bleeding risk is not prohibitive, we can go beyond 12 months. Now, of course, the price we pay with giving long durations of DAPT, particularly with strong P2Y12 inhibitors, is that of bleeding. And classically, we thought of bleeding as sort of this nuisance event that we could quickly reverse. And was rarely fatal, but multiple studies have taught us that this relationship is much more nuanced. This is a paper by Val Gemigli and colleagues where they looked at an ACS cohort from a randomized controlled trial, and they wanted to ask a question of which event, MI or bleeding, carries more prognostic impact. And their insight, which has been confirmed by other papers, tells us that the mortality after a major bleed is comparable to that of a recurrent MI. So these kind of insights tell us that the goal of lowering bleeding should have a priority comparable to that of mitigating thrombosis. And we were challenged in studying these patients at high bleeding risk because we didn't have a real standardized lexicon. And then the Academic Research Consortium in 2019 finally gives us the tools, at least the language upon which we can intelligently speak about the high bleeding risk patient. From this paper, we learn exactly what are the factors that associate with high bleeding risk, and we get a nice definition that tells us that the high bleeding risk patient is one wherein annualized risk of major bleeding is at least 4%. Multiple papers have now validated these criteria. These are data from the Mount Sinai PCI registry that tells us about 40+% of patients undergoing PCI in the contemporary era will fulfill the high bleeding risk criteria per the Academic Research Consortium criteria. And we also know that these patients are at certainly elevated risk of bleeding, as shown in the Kaplan-Meier curves on the left, but as importantly, they're also at risk for thrombotic events, MI, and therein lies our clinical dilemma. We've got a patient population at risk for both events, so how do we uncouple these events to lessen bleeding but don't pay a penalty on the ischemic side? And I'm going to walk through 3 different strategies that have been now tested in randomized trials, endorsed by guidelines, and that we are now using in various permutations in clinical practice. The first that's been looked at the most in studying the master DAP trial is to shorten the duration of DAP. So we go as short as you can, and then after that short duration of DAP, you go to principally aspirin alone or clopidogrel. And this is a strategy that's really been looked at in the true high bleeding risk patient. And in master DAP, the average age was 76, over 1/3 on oral anticoagulant. Notice 1/3 actually presented with troponin-positive ACS. So again, enriched with both bleeding and thrombotic risk factors. In this trial, all patients got 4 weeks of DAP. They were then randomized to just single antiplatelet therapy, which is again principally aspirin or clopidogrel, or continuing dual antiplatelet therapy. And the results of the trial on the left, you can see no penalty to be paid on the ischemic side when you go with the short duration, but you do clearly lower bleeding, and so overall a net clinical benefit. And again, the application of this strategy is really in that, what I say, the quote-unquote true high bleeding risk patient, where you really want to go as short as you can with respect to DAPT. But what about, and in guidelines, we see this has been endorsed in the 2016 ACC-HA guidelines, a 2B recommendation to stop P2Y12 inhibition after 3 to 6 months. ESC in 2018, very similar, and ESC 2020 guidelines tell us after 3 months we can stop the P2Y12 inhibitor. But what about our patients who do not necessarily present in sort of the true high bleeding risk phenotype? So patients particularly with an acute coronary syndrome where we want to give a long duration or a more potent P2Y12 inhibitor, how can we achieve that same net clinical benefit? So these are the randomized data so far looking at aspirin withdrawal. This has been a strategy that has been tested so far most rigorously for this outcome. And these are the trials to date. And in aggregate, this reflects about 23,000 randomized patients, almost 400 major bleeding events, about 700 ischemic events, so a strong evidence base upon which you can draw some inference. And when we pool these data together, you can see on the ischemic side, when we stop aspirin, we pay no penalty with respect to ischemic events. If anything, a trend towards less mortality, and again, large reductions in bleeding. And when we look at the guidelines, you can see 2018 ESC guidelines start off by giving us a 2A recommendation to stop aspirin after 6 months. 2020 ESC guidelines after 3 to 6 months, and the most recent iteration of the ACC-HA guidelines actually say you can stop aspirin after 1 to 3 months with a 2A recommendation. So you can see the guidelines are getting more and more comfortable with withdrawing aspirin at earlier and earlier time points, particularly in these ACS patients where we continue a strong P2Y12 inhibitor. And the second strategy is that of de-escalation. This is a little bit confusing, mainly because of how it's been studied in clinical trials, and there's various definitions out there, but just one way to look at it is when we think about de-escalation, one way to do this is to basically switch from a potent P2Y12 inhibitor to clopidogrel. You can do this guided based on some platelet function or genetic testing, or unguided. You can transition to a lower dose of ticagrelor or prasugrel, but really the concept of de-escalation is a strategy where you still continue dual antiplatelet therapy. You're just lessening the antithrombotic intensity of your strategy. And here are the data thus far, randomized trials that have looked at de-escalation and all of its various permutations. You can see here a pretty strong evidence base, about 12,000 randomized patients, 300 major bleeding events, about 340 ischemic events. And this is also shown up in our guidelines, however, not quite a strong recommendation. In 2018, ESC gives us a 2B, 2020 ESC again, a 2B, and in the ACC-AHA REVASC guidelines that just came out, it's actually not mentioned. We will have to see in forthcoming iterations of ACC-AHA guidelines in ACS if this gets bumped up a little bit. So, in conclusion, short course of DAPT is certainly necessary to prevent near-term atherothrombotic events, principally stent thrombosis. We understand major bleeding is common and associates with a mortality risk comparable to that of MI. The quote-unquote true HBR patient really can be treated with a 4-week course of DAP followed by single antiplatelet therapy. That would be aspirin principally or clopidogrel, and that's the master DAP data. And we've learned that aspirin withdrawal followed by P2Y12 inhibitor monotherapy is now an emerging strategy for our ACS patients. So thank you for your time.
So Usman, that was fantastic. Now I have we're going to start this with an audience question. So I spent a lot of time talking about the virtues of standardized care, and for STEMI, for cardiogenic shock, for cardiac arrest. But this is an area that has become more confusing and more difficult. How many in the audience have a standardized approach to DAP? Exactly. So, and this comes up every week. How many people get more than 10 phone calls a week from primary care, surgeons, your nurse practitioners, right?
Everyone. No wonder.
So this is an area. So Usman, first question, if you are going to have get your interventionists together, we're going to have a standardized approach to this and put it on one slide, what would you do?
So the way, at least I look at it, there are many different, I think, ways, and I don't think one is necessarily, let's say, correct. I would focus first on that true HBR patient. And I always use that because all these studies look at, very different patient populations. And I think the true HBR patient is very different than patients that have been looked at in other trials. So I start off with figuring out, am I dealing with a master DAP type patient? So late 70s, CKD, malignancy, something like that. So those kinds of patients, I feel very comfortable doing a very short duration. And then either going to aspirin or clopidogrel. In my own practice, I don't like clopidogrel monotherapy because of some concerns, so I do want to confirm that they're responders, which is simple PRU test. So once I figure that out, then I look at my non-HBR patients. So my non-HBR patients, I look at, are they presenting with an acute coronary syndrome, would have complex multivessel disease? And for those patients, I've got 3 options. I can do dual antiplatelet therapy, that's class 1 in the guidelines. I can withdraw aspirin, or I can de-escalate. So for me personally, withdrawing aspirin has become pretty easy to do, and so that's what I'll do in a lot of my patients. But I think it's a dealer's choice out of those 3.
So we're going to get comments from the panel. I want to also let people know our plan. So in the interest of keeping more time for discussion on later ones, Dr. Dangas is going to give us 1 sentence or 2 on reversing anticoagulation. And then we're going to, at 11 o'clock, we're going to go on to the next so that we're staying ahead. But why don't we comment? So what do you do for...
So first of all, I'm scared now because one of the antiplatelet gurus is telling me to measure PRUs. Now I don't know what to do because I hardly ever measure PRUs. So I think the issue is we don't even have intra-observer consistency in antiplatelets, right? So many of us tailor it based on the different patients. So getting 5 or 6 interventionalists together in our group to agree on an antiplatelet regimen is going to be very tough. I tend to de-escalate. I use a lot of clopidogrel monotherapy, so I don't know if I'm doing something wrong now.
I too use primarily clopidogrel monotherapy. I like to keep it simple.
I'm still in transition.
So if I have a patient on oral anticoagulation, then I think it becomes simple for me. I take them off of dual antiplatelet therapy regardless of their indication of revascularization. Now, to me, I think the indication of revascularization still is very important to me, whether they had a stent placed for acute coronary syndrome versus stable angina. And the third thing, that we have to think more and more about, or at least I think more and more about, is that how complex was their intervention? Do they have left main stents? Do they have, an SVG? They have had recurrent ACSs. Of course, I'm talking about the non-HBR patient. Then I think it becomes complex, and that's where I try to tailor. But again, I think having a standardized approach would be very helpful.
One of the issues that sort of dictates how we do this is the fact that our surgeons will operate on aspirin, but they won't operate on clopidogrel. So if I have somebody on clopidogrel monotherapy, it becomes a whole issue when you get the phone call for how to prepare this patient for the OR. And I was wondering if anybody had any comments on what to do with those patients and what's the safest approach.
Well, just in short, answering that, that's a very practical. And actually, I had the same independent comment, which I didn't share. He came with the exact same one because it's very practical. Well, I have to switch them back for a week on aspirin and then resume back to whatever they were doing, which is another practical level of the P2Y12 monotherapies, quite frankly. We have an answer, but this doesn't mean it's convenient. We have to, again, write all these notes and, communication, and nurse practitioners have to instruct the patients, etc.
All right, Dr. Henry, you mentioned standardization, and I think the devil's advocate is also personalization. It might be very tough to apply standard to everyone. If it's a simple type A lesion in a STEMI, or a trifurcation left main with 3 stents and residual disease. So yeah, in higher bleeding risk patients, it's very easy to get off aspirin, but we also have to consider that antiplatelets can save us at some point, and we might need to keep them on.
Well, how about the levels of disease? It's not just the stent. Somehow, interestingly, study after study, although we're obsessed about the stents have a lot to do the first few weeks and the first month. Later on, the whole game becomes about the patient and the levels of disease. Is a patient who has only CAD, or a patient who also has cerebrovascular disease or vascular disease, and all that. So our next panelist is a specialist in this area, and she's going to give us her view about that.
So thank you so much. So if the patient has multiple disease and other vascular beds, once again, I would prefer to add an anticoagulant, low-dose rivaroxaban if possible. But once again, if they have other, looking at the coronary artery disease, how complex is it if they don't have disease in other vascular beds, I try to keep them, at least if they're high bleeding risk, ACS 6 months and then de-escalate. Most of my patients, however, have other reasons to be on anticoagulation. So they do an antithrombotic regimen where you have to add anticoagulation, which is not part of our talk, is also an important thing to remember, that some of our patients have AFib and need to be on anticoagulation. And so the DAPT question versus the DAT question then comes in. And so anticoagulation and with a P2Y12 inhibitor becomes my preferred strategy for those patients.
Well, it's great. As of so far, we hadn't even touched the anticoagulant aspect, and it's just the whole discussion becomes even more complex now. By the way, anyone from the audience who want to ask a question, Dr. Brilakis has, I think, a microphone who can give over there, who can ask your question. But I have a question to your response. The study about the rivaroxaban low dose is a combination with aspirin. Given all the other data we have now, in my practice, I go a little off-label in those, and I combine the low-dose rivaroxaban with clopidogrel. How do you feel about that?
As an interventional cardiologist, that would be my preferred as well. I prefer that, but we wait for more data on that as well.
Interestingly. Well, welcome to the nearly no data discussion. That's what makes it interesting, in all honesty. Go ahead.
My question is on high bleeding risk patients. Does the type of bleeding matter? If it's an upper GI bleed, would you consider, switch to a P2Y12 monotherapy as opposed to if it's hematuria from, if it's hematuria, if it's recurrent bruising, is aspirin safer than aspirin monotherapy than P2Y12?
Well, you mean the patient has an active GI bleed or has a risk of GI bleed?
Risk or previous GI bleed, as opposed to someone who has hematuria. If someone has hematuria, I've been told that, aspirin might be better. It's less potent of an antiplatelet, as opposed to if someone has an upper GI bleed, you should switch to a P2Y12. Does that factor into your decision, the kind of bleeding we're looking at?
My general impression is that the peptic ulcer disease is somewhat better served with clopidogrel and relevant inhibitors for the peptic ulcer disease. And I want to come back, though, whenever we use clopidogrel in the situations that we're unsure. In my practice, I use a lot of the PRU testing. So it's the second one in this panel that brings it up to make things even more interesting and guide in some ways, in a practical way, what I do with those medications. Tim?
So I'm going to do, if we get into PRU testing, we're not going to have time for today. No, what I want to do before we go, because I want to go move on to the next, I first want to say kudos to Usman, Dr. Roxana Moran, who's not here today, for Twilight Trial. Because this concept of getting rid of the aspirin was really controversial. And when you went forward, there was a lot of pushback about doing the trial. So the Twilight Trial and this whole thing has really pushed our thinking forward. And there's a lot of reasons potentially, better better PCI, better stents that have allowed this. But really, congratulations for that. George, I want one comment on reversing. You're going to introduce Poonam.
I thought the question was a great transition because you have a problems in preventing and nearly no data, as many panelists indicated. Imagine what happens in the subject that is even fewer patients, those that have an active situation and we're considering some level of reversal, at least to be discussed. Let me just start with some statements that hopefully everybody will agree on so we can go to the more controversial aspects later on. When a patient has an emergency in the cath lab and is on heparin, typically we reverse with protamine, and with no ratio 1 to 10, but there's a maximum of 50 we give. As a subtitle of that, the surgeons use gazillion more milligrams of protamine while reversing the cardiopulmonary bypass anticoagulation. So nothing really bad is going to happen if you give more than 50 milligrams of protamine. That is pretty much all we need, and keep that in mind. Whoever takes a board or recertification exam, this kind of question sort of pans out every once in a while. So the 50 milligram maximum is something that is good to remember. And then everything else we have available is a little bit controversial, to say the least. Controversial or extremely expensive, which also makes it controversial. In the older days, we had the 2B3 inhibitors. We don't use those as much, and we had particularly Riopro, abciximab. That required a platelet transfusion for reversal. Why? Because had a 1-to-1 ratio to the receptor, was a direct binding of that receptor. So you had to give new platelets that were uninhibited in order to do the job you wanted to do. So why am I saying this now? Riopro is not even manufactured anymore. We don't use it. In order to let you think, you need to remember a few things about how the drugs work in order to configure in the active situations what you want to do. The other 2B3 inhibitors, someone may be using aptifipamide or tirofiban, they're not work at the molecular level. We build concentration of those drugs in the blood. Pretty much like ticagrelor works as well. We build up a concentration in the blood and then inhibits the receptor. So if you give more platelets, there's a lot of drug around, the new platelets are going to be blocked. Why? Because there's a lot of drug around. Unlike the clopidogrel and the prasugrel, that they work over the irreversible binding, and if you give enough new platelets, you will get some level of reversal. So you need to remember that these drugs work differently. Do I have a prescription to tell you right now how much you need to give? No. So if you think it's so acute, then you have to do something with a platelet transfusion in patients who have or you simply can prevent it by saying, okay, if you're doing a CTO procedure, please don't load with Efient before you cross, or don't load with Brilinta before you cross. Why? Because they're very potent. And you do afterwards, you can do it, or you can use other agents. Cangrelor is not controversial because it goes away very quickly. You don't need to worry about the reversal of that. The most interesting reversals, and that's where we're going to come now, is what do you do if you reverse a patient who's bleeding and is on this difficult combination regimens that include an anticoagulant, like rivaroxaban, apixaban, and all sorts of others we have. Well, there are drugs out there that are very expensive, and they're not in the formulary of many hospitals for these very reasons, and also with the reason that each one of them has a contraindication. You know what that is? Life-threatening cardiovascular thrombosis. So what are all these all patients have? Well, they are at risk for life-threatening cardiovascular thrombosis. So as you can see, it's not easy to say, okay, there's a new drug is approved there to reverse X and Y, but if you read the print, it's really not tested in our patients. If you give that drug, maybe you reverse it too much, you have a heart attack immediately. So there's also this concern. So I don't know if others share this concern. And we can invite some comments about this very controversial, in my point of view, aspect. Our emergency room and our CCU are more comfortable reversing this, doing something with FFP or K-Centra, which is essentially a super concentrated FFP. But I don't think they're missing the fact that we don't have any of those reversal agents in our formulary until very recently.
The population where this becomes even more troubling is the pre-transplant group, where our transplant surgeons don't want patients on DOACs if they're going to be listed for a transplant. And an organ becomes available, what do? They have hours to get that organ in. They don't want to use a Dexanet or these other reversal agents because of the thrombosis risk. You can actually thrombose, let's say, the renal artery when they sew it in. And same thing with the liver situation. So that population sometimes gets turned down if they can't take warfarin. And we don't know when they're going to get transplanted. So this is, in that big patient population, this is a big concern.
Yeah, I mean, the decision tree is sort of endless and full of very rare scenarios like this one. And in all honesty, in our practice also, we're reversing Coumadin with vitamin K, but we really disallow or advise against IV vitamin K because we're afraid of allergic reactions and overcorrection and ischemic events. So we get oral or sub-Q maybe, but nobody's very enthusiastic about it. Why? Because it's phased in over hours or days. So how is it going to really help you immediately? So we have all those concerns that all those things are available on the shelf or on the internet, let's say. They're not really a pragmatic answer when you need them. Tim, what do you think? Any comments, by the way? Anybody has a difficult case to ask us about from the audience, please go ahead and raise your hand.
So we're going to try to stay ahead. So I am going to say, well, we're going to move on to Poonam Velagapudi. Is going to tell us about CAD in women.
And we thank Dr. Shaw, who's helping out with this presentation as well.
Full disclosure, these are Jackie's slides. She couldn't be here today, so I'll be filling in for her. So if any questions that I can't answer, you can direct to her. So it's really important that we know the differences of CAD in women, especially in the United States, because we have so many women. We have about 13.5 million women with cardiovascular disease, as opposed to, let's compare it with breast cancer, which is about 3.5 million. And it is the leading cause of death among women here in the United States. And so it's important we understand the risk factors, the pathogenesis, how do you diagnose, and then how do you treat in order to improve the outcomes. So these are Jackie's disclosures. So this is just the numbers that I was talking about. The number of deaths in the United States, about 1.3 million in 2020, and you can see the top cause is cardiovascular disease. And there is a lot of difference between women and men, and if you ask me what's the difference, everything. Really, the risk factors are not the same. The presentation can be different. The differences in access to care, that's really important. Women have less access to care and then less guideline-directed medical therapy. And then there's differences in outcomes with, both in hospital as well as the short-term and long-term mortality being higher in women. And you can relate it probably to smaller blood vessels, more bleeding, et cetera. So what are the risk factors in women that are different? So the traditional risk factors we all know, diabetes, hypertension, physical inactivity and things like that. But there's other risk factors in women that we have to keep in mind. This is premature menopause or any gestational diabetes or gestational hypertension, PCOS and things like that. And then there's other things that we don't usually recognize, the psychosocial factors, and as well as the socioeconomic and the health literacy, which sort of is lower in certain women. Now, the manifestations of cardiovascular disease in various categories are also different. We will stick to the ischemic heart disease. So symptoms vary between sexes, and we know that. Women don't present with the typical central chest pain. There's other ways that they will present that we'll look at. And then there's non-obstructive atherosclerosis in women, in addition to the obstructive, and that's what we would also look at in this presentation. So these are the MI symptoms reported by women versus men. And if you look at the left side, those are the classic symptoms, which are more common among men. Only about 87% as opposed to 90% will show these symptoms in women. And then look at the middle box. These are additional symptoms that women present with. So you can have nausea, fatigue, indigestion, dizziness, palpitation. So it's really important when you have these women present with these symptoms and there's the risk factors, and it's really important to consider and not just push them away. So obstructive CAD is only the tip of the iceberg in women. There's various other things. You have coronary microvascular dysfunction, and then there is the diffuse non-obstructive atherosclerosis. We have to keep in mind that all these are important because the outcomes are not as bad or the events are not as bad as the obstructive CAD patients, but still they're not the same as our general population without any disease. And then the ischemic heart disease, the whole gamut would be stable coronary disease, which is obstructive CAD, the atherosclerosis on the far left. And then the ENOCA and ANOCA, this is angina with no obstructive coronary artery disease, or ischemia with no obstructive coronary artery disease. And on the right is the ACS, which can be the STEMI and the N-STEMI unstable angina that we all know about. But in addition to that, we also have MI with no obstructive CAD. And it's really, among the entire ACS patients, it's 6% of MINOCA, whereas in women alone, 10% of the ACS patients will be MINOCA as compared to men, where 3% of ACS is MINOCA. And so what are the causes of MI in women? Again, there's obstructive CAD on the far right of the slide, and then the non-obstructive CAD, so it could be atherosclerosis, it can be microvascular dysfunction, vasospasm, SCAD, or thrombi. So basically, the idea is that the CAD is less than 50% occlusive to the vessel. So that's really important, MINOCA. To make the diagnosis. And then the non-ischemic causes have to be excluded. And these can be myocarditis, Takotsubo, and the non-ischemic cardiomyopathy. So this is the big important slide that you should take home, that these causes have to be excluded before we make a diagnosis of MINOCA. So again, these are just the numbers. The estimated incidence in the US is about 50 to 150,000. And MINOCA is 2 to 5 times more common among women, more common among younger patients and African-American patients. And then, as I just mentioned, we have to exclude the non-ischemic causes before we diagnose. So why is it important? They don't have obstructive disease. Why do we care? Why do we treat them? They present with symptoms, but it's just not about the symptoms. Their event rates are also higher. So this is just data from the ANZAC's QI registry, which has patients who are presenting for coronary angiography for MI in New Zealand. And you can see that the patients with Minoka have a higher all-cause mortality in MI as compared to patients with no cardiovascular disease, albeit it's less than those with obstructive disease. So they're definitely higher, so 4.5 times with the risk. And then this is the in-hospital and long-term mortality after Minoka. Again, you see at different time points that these patients are, have a higher mortality as compared to the general population, even at 1, 2, 3, and 4 years, which is the long-term outcomes. And these are MACE outcomes from Sweetheart Registry and CATH PCI Registry, which you can see the MACE events are at 1 year, 18%, and 24% at 4 years. So this is a big problem, and it's really important that we diagnose and treat. So I'm going to go over this diagnostic algorithm really quick. In the far upper right hand is the diagnosis of Minoka. So you need to have the rise and fall of the tropes, and then you have to have the classic chest pain or EKG changes. And then the most important and the third thing is that there is non-obstructive CAD, so less than 50% obstruction of the epicardial vessel. And if anything is amiss, then you have to make sure that you also rule out the other important causes of MIs like sepsis, PE, and the other big things. And then coming to the middle section, which is the yellow, it's important to have the, do a thorough review of the cath, because sometimes we may not see a major vessel occlusion, but the MI may be caused by a distal vessel occlusion or a side, a little side branch and things like that. So you have to make sure that that's not the cause and exclude those things. And then an imaging, maybe CMR, would help rule out the other non-ischemic causes. And then once we have our diagnosis of Minoka, then you want to identify what is the cause of Minoka. So 2 things will help. One, during the cath and intravascular imaging, and then you can diagnose your routine, the plaque rupture or erosion and emboli and SCAD and things like that. Again, SCAD, you have to be careful. Not every SCAD needs a imaging. You can diagnose that angiographically, and unless there's a question, then you could use imaging, because any wiring and things like that can worsen the dissections. And then you have the intracoronary functional testing, which helps us identify the microvascular disease and then the vasospasm. So those are the different things that can cause Minoka. So this is data from the HARP study. So the HARP registry actually is a multi-center. It's an observational registry of patients with MI who get coronary angiography. Now this study, the HARP was presented in AHA at 2020, and they looked at about 300 women who had a diagnosis of MI, and out of these, 170 were diagnosed with Minoka. So these patients got multimodality imaging, OCT during cath, as well as CMR. And if you look at the lower box, which is in green, the cause was identified in 85% patients when they got both OCT and CMR. And about 50% had an ischemic cause. So you can see in the CMR group on the right, infarction was 32% and regional injury was 20%. And the non-ischemic causes were about 20%. And then on the left, all the way on the right, OCT found the cause in about 46% patients. So a combination of imaging really helps identify the diagnosis in 85% of your patients. And why is it important to know the cause? Because the treatments, I'm not going to go through each of these because it's going to take a lot of time, but understand that the treatment is different with each diagnosis, and that's why it's really important that we differentiate and know what the exact diagnosis is. Now, are all dissections Minoka? No. A portion of them will be. Again, like you can see on the top, SCAD with less than 50% stenosis would fall in this category of Minoka. So now let's move to the next, which is Inoka and Anoka. This is ischemia with no obstructive CAD and angina with no obstructive CAD. So the 2 top causes for this are coronary vasospasm and coronary microvascular dysfunction. And then you can see there's myocardial bridge, which is really severe, or like esophageal spasm and musculoskeletal, those are the other ones. But the top 2, the coronary vasospasm and microvascular dysfunction, are really important to keep in mind. And again, just like Minoka patients had worse outcomes compared to the general population, same thing. The event rate is 2.5% a year for those patients who had Inoka in this WISE registry as compared to age-matched control. So that's death or any cardiovascular outcomes. So how do we diagnose these? Has to be done in a very meticulous and a systematic fashion. And if on the top, on the right would be macrovascular, and on the left is microvascular, and then whether it's endothelium dependent or independent. So if there is a response to nitroglycerin, you have a lot of vasoconstriction, then you know that it's endothelium independent and macrovascular disease. Then you give the adenosine, you can use your pressure wire X, and then based on CFR and IMR, you can diagnose the microvascular endothelial independent. Now, after that, you do the acetylcholine. On the right side, you give them in increments of 20, 50, 80, on the left to up to 100 or even 200 if you don't have response. And then if it's a macrovascular, you will see a 90% or more constriction in the vessel. And if that's not present, but they still have chest pain and other things, then you diagnose the microvascular. Now, why is this important? Again, a lot of people say, oh, the treatment's going to be nitro. But you do need a diagnosis. These patients keep coming back over and over again. And there are some subtle differences between the therapies. And that's really important that we have a diagnosis so we can appropriately treat. And then this is just the targeted therapy based on the various subtypes. And as you can see, the vasospastic coronary vasospasm is a smooth muscle problem. And so calcium channel blockers and nitrates are the treatment of choice, and then we avoid beta blockers in those patients. And then for the microvascular disease, you can see these non-endothelial dependent, which we treat with the ACE, ARB statins, beta blockers, ranolazine, and we avoid nitrates. And then for the endothelium dependent, that's the treatment of choice. Again, I will end with this. This is the Lancet Commission that was recently established with the goal of reducing the burden of cardiovascular disease among women. It has 4 aims: to reduce the global burden of CVD in women by 2030, to promote cardiovascular health and improve outcomes for women across the world, to identify the gaps in evidence as well as in the research, treatment, et cetera, and improve access to care and prevention in women. And then finally, to ignite global awareness of sex and gender-specific disparities in CVD and provide a springboard for the future research. So this is an important commission that was recently established, and I'm going to end with this slide. So thank you again.
All right, Poonam, that was excellent. First, I want to ask people a question. I think with Minoka is a really important issue, and Minoka STEMI is different than Minoka non-STEMI. So when you have a STEMI and you have a patient who has chest pain, ST elevation, comes to cath lab, and they have minimal coronary disease, how many patients make sure that they get a troponin between 6 and 24 hours? There was just, Mort Kern does these essays, and a lot of really experienced interventional cardiologists said, no, why would you check a troponin? Well, there's a big difference between a patient who's a false positive and a patient who has a positive troponin. And I think we just have data with about 500. So 5% of our STEMI population are Minoka. And the 5-year outcome of a Minoka STEMI is worse than a coronary disease STEMI. And part of it's because we ignore them. We don't have a diagnosis. So I think really excellent talk. Comments? Let's go to your side first.
Yeah, excellent talk, Poonam, especially ad-libbing for someone that's not here, so thank you so much. Once again, coronary disease in women, recent guidelines reminded us that it's under-recognized, undertreated, class 1 in the guidelines. And so it all starts with recognition in women. Women still present with chest pain as the most common symptom, but more commonly in women, they also present with, at least 3, usually about 3 other symptoms that may not be the traditional, what we call coronary artery disease-related symptoms. But chest pain is still one of the commoner symptoms that women present with MI. But we always have to have that high suspicion when the patient comes in to the ER. Studies have shown us that that even women, the problem is both on the systems of care as well as in the women themselves not presenting when they have symptoms. A recent AHA survey that was done showed that, when a woman has chest pain, 50% of them were less likely would call 911. But if someone else had chest pain, more than 70% of them will call 911 for that person. So once again, both on the side of the patients as well as the side of our health systems, women do need to present recognize that their symptoms could be related to coronary disease and come to the ER and be evaluated. But even when they do come to our hospital systems, it's also the onus is on us as healthcare providers to make sure that we come to the bottom of their symptoms and not dismiss them. We know that women have, as Poonam pointed out, menopause can occur, and also other things like, that we also have to keep on our radar. So we had a presentation yesterday about SCAD. We should know the angiographic features of SCAD when we do a coronary angiogram on these patients. And then also remember microvascular disease. So once again, the fact that we don't seek obstructive coronary disease doesn't we don't just stop there, but further dig in to find out why they're presenting. And it's also important for us, as the Lancet Commission reminded us, that getting women into clinical trials is important. They're underrepresented in trials, and so as much as we can encourage, we should go out, we should make sure that we recruit more women into trials, and there are different strategies to ensure that this can occur.
Well, and that's a great points, and particularly also have to remember that in several trials, the group of women was higher bleeding complications and bleeding risks. And I do remember in a seminal trial, a tactics TME18, the women did not seem to derive benefit from the early invasive strategy as much as men. And that, I think, led to a maybe more widespread application of an early conservative approach for women more so. And of course, this was the era of the 2B3 inhibitors and femoral accesses and all that. I think the current pharmacotherapy, particularly as discussed in the previous talk and discussion time, combined with the radial approaches, make those things more safer now to employ and have nothing to do with the tactics TME18 era. And we should be pursuing more the diagnostic evaluation with an eye to have a definitive diagnosis. And that gives up to us now to trickle down, is the cath lab, is any cath lab, is your cath lab really equipped and ready to go? And I don't mean equipment-wise, but mindset-wise. The nurses, the doctors, they all know what to do if you want to investigate physiology and the different aspects we just saw tabulated here. And the answer is probably that many cath labs are not yet. And I think that's where we got to go. And again, this population with a non-obstructive coronary disease or not clearly obstructive coronary disease is more prevalent in women, but in theoretically any patient could benefit from it. And we should kind of reach a level that our cath lab can implement this testing with zero warning, let's say. So this way it can be implemented seamlessly and in all patients that we need. Am I the only one at the cath lab is promising that, or as perhaps many other people feel that they're ready to go, or who is, let's ask the audience by raise of hand, who has the cath lab availability of the checking of macrovascular disease? Let's say you do a regular cath, it's not obstructive or normal coronaries. Can you just, at that time, call for advanced testing for macrovascular disease or not? Who says yes? Very few. And no, not yet, I would say, not yet. Well, several people, and I'm sure several others embarrassed not to raise a hand, including myself. Any other comments?
That was a great talk. I just want to press on the idea of the CMR. CMR is, I mean, non-invasive testing might be great, but CMR have saved us a lot of time, identified a lot of pathology that we would not have identified in Minoka. Throughout my training, I've seen 2 cases that were identified as true STEMI out of a very small branch that was not diagnosed. And the value of this is that you aggressively treat these patients. You don't ignore the statins, you don't ignore LDL, you don't ignore DAPT, and that's your point. I mean, we don't ignore them so their outcomes are not worse than obstructive MI.
Any comment from that panel? Perhaps?
I think one challenge is, what medical therapy should these patients be on? Is this the classic medical therapy, aspirin, beta blocker, maybe a second antiplatelet. I don't know if there is any comment on that. Should we be treating these patients with dual antiplatelets like for 1 year, or I don't know if Usman, you want to answer?
Well, in the CURE trial, they did include several patients that did not undergo any revascularization. So the entire PCI, the entire CURE population included medical therapy, bypass, and PCI. So in that context, we should treat them no other way based on that trial. I don't think we'll have a subsequent trial. And we're in a difficult era now that we have a lot of patients who are undergoing testing, and it's difficult to have a study if you don't know what's the endpoint. And if you don't have an endpoint, if you don't have something to measure. So now we're in the funny time that we have something to measure, and we can start having studies because we have something to measure. Dr. Fearon is going to have a comment, I'm sure.
Thanks, George. Yeah, I think that gets to the crux of the matter, that we really need to do further investigation to figure out what the culprit is in the Minoka patient, if it's plaque rupture or if it's something else, and that will dictate, whether we're going to do dual antiplatelet or not. And I'd just like to make a plug. Tim and others are involved in this microvascular network that we've created nationwide to help increase awareness of this issue and the need, and to help facilitate your cath lab instituting these analyses in our patients, either with Minoka or with ANOCA. And so we have a lot of educational programs that we're creating. There's some papers that'll be coming out soon in JACC to highlight how to incorporate and start a program at your center. So more to come.
Yeah, that's great. The final comment is sometimes what the main finding is low CFR. This means what would tell the patients to join an exercise program and get in shape.
Yeah, and one comment as we're getting into refractory angina, which touches on this. So our women's heart program, it's really exploded, and I'm probably doing 5 coronary reactivity tests per week right now. And the average person that the average 75% are women. The average person has had chest pain for almost 10 years, has seen 3 different cardiologists, has had 4 angiograms or CT angiograms, and has more than 5 stress tests, and doesn't have a diagnosis, or has been told they're crazy. This is a huge unmet need. You can make a big difference in people's lives. So I'm going to spend a couple minutes now talking about refractory angina. I don't own anything, but I've been in a huge number of refractory angina trials and been doing this for a long time. I'm currently the co-national PI of COSIRE 2, and I'm on the steering committee for the Xylacor trial. I'm going to make this focused for interventional cardiologists. So number one, there's 15 million Americans that have angina. It's a huge problem, and a lot of it's untreated. Another key point is that we don't have registries. This is data from our refractory angina registry. These people live a long time. In fact, their mortality is not much higher than age-matched controls. And that's because we've done really well with secondary prevention. So the mortality is only about 3% per year. It's not a dying problem, even when you have severe, terrible obstructive coronary disease. It's a quality of life problem. And there's high utilization. So you can see, this is our curve. It's really only about 3% per year. Who are these patients? So we've been successful, I think, in putting really 4 different phenotypes. So on the left is A. Phenotype A is normal coronaries. So I've put patients who have INOCA or ANOCA, who have class 3 angina or more. That's really refractory angina. Severe chest pain, not amenable to revascularization, and pain despite medical therapy. And phenotype B is sort of the classic CTO patient, so a single territory risk. And we've done a great job with CTO PCI really helping that group. Phenotype C is your type 1 diabetic with just diffuse distal and side branch disease. That's obviously, we know, super challenging to treat. And phenotype 4 is sort of the end stage. They've had 2 bypasses and 17 PCIs, and they're still having chest pain. So another really important point about this is we call these patients no-option patients. But it's important to understand, is that really true? If you look at all the trials, about 20 to 25% of people have subsequent revascularization. So a really important point when you see these people is look at their angiogram. And when we looked at these patients, the patients who actually had new lesions, 48% had new lesions, and a lot of that is in bypass grafts. And then 21% had restenosis. So really almost 70% had something new. So look at the angiogram and say, is there a place where you can get worse? Now, so we've had a chronic angina, complex coronary disease, however you want, a refractory angina clinic for a long, long time. And what we do is, number one, you review, are they on optimal medical management, risk factor modifications, are there revascularization options? And we've gotten better, so sometimes that happens. And then you need to have a large portfolio of options available for these patients, and that includes angiogenesis, EECP, neurostimulation, novel drugs, TMR, and then novel interventional techniques. And we're going to concentrate on two, what's available now. Another really important point about angina is angina we think about as a supply-demand, but another really important point is the neurogenic component of angina. And we all know patients who have terrible coronary disease have no angina at all. And then we know patients who have just angina all the time. So perception of chest pain or nociception problems are really an issue as well. So what about catheter-based cell and gene therapy? So first of all, there's nothing improved right now, but the problem with cell-based therapy is actually the business plan. And we actually published, this is actually data that we published in the European Heart Journal. And if you look at consecutive randomized, double-blind, placebo-controlled trials with CD34, significant improvement in exercise time, significant improvement in angina, and actually improvement in mortality. So it's the business plan, it's not the fact does it work. And what's going on right now with regenerative medicine? Really good data that's going to be published at ESC that shows this is a gene a gene that increases multiple isoforms of VEGF, significant improvement in PET scan, and I can't talk about the data at ESC, but it's positive and it'll push us forward. The other one, there is actually a cell therapy trial that's ongoing right now. So for those of you who want these options, there's two, both a gene therapy and a cell therapy. But I'm going to spend more time talking about the microvasculature. Probably the way that regenerative therapies do is also help the microvasculature. And this is really a big issue. Almost all of our unmet needs are related to microvasculature. Microvascular obstruction in STEMI, Anoka, and Minoka. HFpEF, 75% of HFpEF patients have abnormal coronary flow reserve. And then post-PCI patients and post-CTO patients, a lot of those patients that keep having pain have actually microvascular disease. So this is actually coronary sinus reducer. It really is patterned after the Beck procedure, which was pre-bypass, but they close off the coronary sinus or put a stenosis in the coronary sinus. And actually there was improvements in angina. That's led to the coronary sinus reducer, which is an hourglass-shaped stent that you put in the coronary sinus. And the way that it works is it changes endocardial to epicardial blood flow. It's complicated and can't do this in 5 minutes, but I'll also tell you there's data I'm going to show at the end that it increases coronary flow reserve. So I think a lot of the way that it works is with microvasculature. COSIRA-II trial published in the New England Journal, 52 people got the reducer, 52 sham, significant improvement in angina. So this led to approval. It's approved in Europe, more than 4,000 have been put in. The stent, this is a show the stent, it actually creates a stenosis in the coronary sinus, so it decreases outflow. And by doing it, the stent actually stays patent. So we have long-term looking at 15 to 20 years that the stent stays patent, but there's there's a gradient for outflow. This is the COSIRA-II trial, which we're enrolling in right now. So it's a randomized trial. This will hopefully lead to approval in the United States. And all of you who are interested, we need more sites and we need more people enrolling. So this is randomized to COSIRA versus the reducer versus placebo. It's an excellent trial, really well done. Class 3 to class 4 angina, maximal medical management, severe coronary disease that's not amenable to revascularization, and walking between 2 and 8 minutes on the stress test. Another important point, we have registries for microvascular disease, for right-sided ischemia, and for patients that can't walk on a treadmill. This is the issue about ANOCA. So patients who have ongoing chest pain despite medical therapies have worse outcome if you have an abnormal coronary flow reserve. So you need to do attention to that. This is actually the coronary sinus reducer data that was presented at TCT, shows improvement in IMR, improvement in coronary flow reserve, and that translated to improvement in symptoms. So the final point about this is when patients have angina, 3 things to remember. So you can have microvascular dysfunction, you can have obstructive coronary disease, and you can have a problem with vasoconstrictive disease. So these are complex patients, but there's really, my goal is you need a heart team approach that actually approaches them. And we know by having a dedicated angina clinic that at the end of 1 year, 85% of patients had an improvement in their angina class. So you can do it if you take care of them. Thanks.
Tim, one quick question. Where can you find access to the trial? Because I know many patients want to be referred for the trial, but there's only a few centers in the US. So how, if someone wants to refer someone to get a coronary sinus reducer these days, how should they go for that?
Yeah, okay. So that's a complicated question, but I will tell you it's overwhelming me. My clinic on Tuesday, I had 24 patients and 16 of them were refractory angina coming from all over. So the point is, you know, if you have it, here's what I'd say. I would say for large practices, all should have a dedicated complex coronary angina, refractory angina clinic. Number 2, I think you have to have a team approach, so I have a really good relationship with our CTO team and with the Women's Heart Program. And we coordinate it together very much. And then we have multiple options available for these patients. And I think it's an individualized approach when you come to a clinic and do it. But if you don't have at your institution, send them to some place that does. You know, that's what I'd say.
I mean, again, the more testing you do and the more you look at these cases with a fresh set of eyes, that you find more and more. I think the terminology of a no option is a negative terminology, and the refractory terminology is much better because that's positive, identifies a problem, and we seek solutions. The no option seeks no follow-up. When I hear someone is no option, then why you send it anywhere? Why do any other thing? But I think these 2 last talks are actually very complementary to each other because this is the new era and the new wave, if you want, of cardiovascular treatments coming up. And I don't mean specifically the reducer, perhaps, or including of the reducer, but many more others about the importance of the microvasculature in each one of those cases that are formally deemed no option. One of it is to target the LDL less than 50 with any means of injectable medications you may need in order to achieve that. That's another aspect that is also new. We didn't have these medications 10 years ago, and perhaps we didn't even learn how to use them until maybe a few years ago. But that's again another aspect of like optimizing the medical regimen. There's a lot to be said about that.
Yeah, great talk, Dr. Henry. And I want to reiterate what you just said, Dr. Dangas. All our practices are different. You know, some of us are big practices and some of us are small. But regardless, I think that you just said that, and I want to make sure the audience hears it again. Just because we don't have something at our hospital or practice doesn't mean that we can't refer the patient to where they can get it. So once again, always remember that we work together as a community, and if we don't have something where we work, then send the patient to where they can get the care. Thank you.
So one question I have for you, Dr. Henry, why do you think something like EECP has not taken off? Like for example, in my town, I don't know who is doing it at all. So is that an option that has not worked, or there's no reimbursement, or what are the reasons.
Yeah, it's too hard to go through all the options in a short time, but EECP plays a key role in our practice. And right now, we have a 4-month waiting list. And so we just have a paper that's going to show for patients with CMD, and these are still having class 3 angina despite medical therapy. And there's a 75% improvement in patients who have microvascular disease. I don't know that it works very well for spasm, but for obstructive coronary disease, too, 75% of people better. And then the third one, for long COVID right now, we have more than a couple sites put together. We have more than 250 patients, and we see a significant improvement because part of long COVID syndrome, there's a percentage of those patients that have abnormal coronary flow reserve. My last comment would say about the no option thing, I completely agree with you, George. We actually called our clinic the Optimist Clinic, Options in Myocardial Ischemic Syndrome Therapy, because who wants to send their mother 5 hours to drive to go to the no option clinic? All right, I'm going to let you introduce the next speaker.
Dr. Henry, one question more. What about the utility of cardiac rehab in these refractory non-option patients?
Critically important, makes a huge difference. One of the really big things about this is anxiety, is people have anxiety. So what I try to get people to understand is this is not a dying problem, this is a quality of life problem. And we're gonna do things to improve your quality of life. But another really important question I ask is, I think it's underestimated, the impact. So one of the most important question is how far can you walk? And you're surprised with the number of people that say 2 blocks and they're 55 years old. And if you only can walk 2 blocks and you're 55 years old, you have a problem. We can make you better.
All right, then let's move now from the no option to too many options. Let's go to angiography and PCI in TAVR patients. When and how by Dr. Lopez. And stay tuned for yet another controversial topic right after.
Okay. I'm not sure this is a very controversial topic, but a troubling one for sure. So I'm John Lopez from Loyola University Medical Center, and it's my first time at CVI, and I love the format, so I don't think Manos was here, but thank you for having me, and great setup. So these are my disclosures, and let's move on. So I'm going to start and do this in a case format because one of the messages here is that nobody does a lot of these cases, and I think our experience should be buttressed by the experience of others. So this case exhibits a lot of the points I want to make that we all should know about how to do these cases, and we'll dive into it. So this is a 61-year-old gentleman who had recurrent angina just 3 months after a TAVR. He had a complicated history. He had coronary disease and had a bypass a few years before with an unusual bypass situation. But in the last year prior to his TAVR, had recurrent angina and multiple circumflex revascularizations. Had heart failure with an ejection fraction of 30%. And had a TAVR with a 29 core valve done 3 months prior to this admission for unstable angina. At that time, he only had 2 bypasses that were open, a lima to a small diag that didn't really fill his LAD, and a vein graft to a distal obtuse marginal branch. He's diabetic, hypertensive, and importantly is an end-stage renal disease patient on dialysis where we knew that the likelihood of him coming back for yet another procedure after his TAVR was not low. And one of the messages here in retrospect is that, I had wished that our heart team or valve team had decided on a different valve for him, right, going into this, knowing his probability of coming back for another procedure was pretty high. But at the time, this is one of these guys where you've revascularized him and you're sort of not sure that he can wait 6 months or a year to get his TAVR done. So it was all done in pretty quick order. So, a number of the questions that arise beforehand is what's the best approach in a patient with a core valve or a self-expanding supraannular valve? How do we deal with the issues of coronary engagement? What additional tools should be in our toolbox for doing these kind of cases? And are there situations where we should think up front about the need for hemodynamic support? And all of these questions came to light during this particular case. And I show this here to recognize the fact that you really have to understand the makeup or the construction of your valve to understand where it is in relation to your coronaries themselves, right? That information is readily available to you for most of these cases before you start, and preparation is a big part of this. So our plan going into this case, because we did understand the anatomy a little bit, was that we were going to use femoral access. We understood the anatomy that he likely had left circumflex restenosis. We had chosen a Guy's catheter up front using the sort of the current recommendations, which are to downsize your guiding catheter a little bit in regards to length. And we sort of had thought about the possibility that this was a guy who was going to need hemodynamic support, and for this reason. So he comes in, has this diagnostic angiogram at an outside hospital, non-selective engagement. We see sort of problem at the origin of the circumflex. We don't have the greatest images because it's a non-selective engagement, but there's also concern here that there's an issue related to his LAD as well. So he comes into our lab, and we repeat his images here. We have a 7 French guiding catheter. We sort of quickly recognize that this is a more complicated case than we had bargained for, right? He's got filling defect in his proximal LAD, a filling defect in his circumflex within the stented region, disease in the left main as well. And one of the problems we encountered here really right off is with this 7 French guiding catheter that we engaged through a cell that was lower than the coronary ostium itself, which is a problem and not the way I would want to do this. And on sort of taking that, trying to engage that catheter, this catheter gets stuck on the cell itself, and on removing it, we find that his LAD is occluded. He's got thrombotic lesions in his left main, circumflex at the right time, and sort of reminds me at the time of that old Mike Tyson saying, right? Everybody has a plan until you get punched in the mouth, right? So at this point, we switched strategies very quickly. We've sized down to a 6 French guide. We've determined to use a guide extension in this situation, have wired the LAD, have wired the circumflex, and sort of, fortunately, have given him some hemodynamic support with a balloon pump that we had prepared for, and are able to both stent his LAD, reestablish flow in his LAD, restent his circumflex, cover that left main, and get him out of town as quickly as we can, and he does really quite well. So our initial steps then, which illustrate a lot of the points that are worth making here, are that even though we had sort of diagnostic images, sometimes they're not that great. Sometimes what you have to work with are non-selective or less than ideal diagnostic images. So we had a plan, but we had to change it based on this LAD occlusion. We had prepared for the possibility of hemodynamic instability, and fortunately we did. We were able to put a balloon pump in very quickly. We switched plans up front to a smaller guiding catheter, 6 French, small size. We sort of used a strategy of using a guide liner, which is really very, very important in these cases, almost routine, and went ahead and treated both his LAD, his circumflex, kissing balloon inflations, the whole ordeal to get this guy improved. So what are the real learning points here? Number one issue, right, it's indication, right? This guy clearly needed to come. He had unstable angina, had a syndrome he wasn't doing well with, but that's not always the case. And I think in general, we should have a fairly high threshold to bring these patients back for angiography if we can manage them otherwise, right? Preparation is clearly important here. In this case, and many of them, you're going to want to choose femoral rather than radial cases to get access to the location you want to, especially if you're interested in having a coaxial selective engagement. Recommendations typically suggest that we should size down. Sometimes you need a longer tip. And a Khatri right guide is often recommended. There are times where you'll need to use a multi-purpose and snake it down there, especially for a right coronary. If you have suboptimal or non-selective engagement, stiff angle glide wires, fishing technique, and even a guide extension is an important tool in your toolbox. And then just remember that selective coronary engagement is challenging, especially when you're using a core valve, right? So if you look at the series of diagnostic angiograms post-TAVR, the failure rate for a core valve in getting diagnostic images is not insubstantial. It's on the range of 7 to 17% of these patients. Those things are predicted by an oversized valve compared with the sinus of Valsalva, the implant depth, right? A deeper implant gives you a higher risk of permanent pacemaker. More shallow implant gives you more difficulty accessing the coronaries after your procedure. And sort of this issue of commissural alignment should also be considered. So in reviewing this topic, I recognized or learned that there is actually an app out there that may be helpful to some of you. Looking at engagement, sort of looking at case studies and how this is done. And again, since very few of us have a lot of experience in this world, it's a good tool. And I also sort of leave you this reference for this table that's in a paper by Valvo in Eurointervention in 2021, and I don't see the reference on here, so I apologize for that. But it's a nice little workflow of how to work through this issue of coronary access in this situation. So I'll stop there.
Oh, this was great. This was great, and indeed the problem, or this is going to only be increased in numbers because we perform TAVR now in lower risk patients with longer longevity, and just by statistical point of view, greater chances to need selective coronary angiography and follow-up. Anand.
Yeah, I had a few comments. First, we have some prospective data that doing PCI before TAVR doesn't seem to make a difference in hard endpoints, right? And we have actually ongoing randomized trials to look at that. But I think that data is often misinterpreted somewhat. At least in my practice, I feel like we're not looking at symptoms in those studies. So angina, shortness of breath. Patient comes in, they're short of breath, they have chest pain, they have aortic stenosis and coronary disease. I really just don't want to treat the AS and then hope that their symptoms all go away. Now, we do that sometimes in the 90-year-old patient. We just treat their aortic valve and see how they do. But in most of my patients, I try to treat the proximal significant coronary lesions ahead of time and then treat their valve. Not because I think that makes the TAVR necessarily always safer, but we need to address all their symptoms. The second point is, like in this case, I probably would have gone sapien. I would have done a S3 in that case because coronary access is a lot easier, and I think no matter what, that's true.
I think certain hospital systems want you to use a certain valve because of cost issues, and that may be playing a role here. One point that I wanted to make in the intervention, and I think great job in this intervention, especially after finishing the intervention, when you are pulling out the equipment, it's important to disengage the guide in a timely fashion. You had your guide liner in, but don't take, like typically, when you finish an intervention, you get your wire out and your guide is still engaged. Don't do that in this situation because your guide might get stuck. You want to get your guide out of in the aorta before you take the wire out, because otherwise if the guide gets stuck, people have lost patients like that.
That's a very important, a very, very important technical reason. And in addition to that, in such cases, I always use a somewhat long sheath, at least 25 cm, to also handle any iliac tortuosity. So in any manipulations we need to do either before or after, you don't have another add-on complexity from down below that may limit your options. Other thoughts? Tim?
All right, so, I think this, first of all, John, terrific job. And I think the issue of prior to TAVR is really one of the most controversial things right now. We at the Grenzig meeting, our last Grenzig meeting, we had a session about, do you revascularize or do you not? And it ranged from Adam Greenbaum, who says, I don't even look at the coronaries, maybe never doesn't look, but, in other words, never, to Raj Makar, who will say, fix everyone. And how do you do it? So I think we really need trials that randomize people and that are well designed to do that.
Well, also those trials are going to be extremely long term because, the picture of a core valve with significant CAD is the punch of the face in the face that Mike Tyson was referring at. And that's when people have no plan and you wish you had done something different 10 years earlier. Okay, let's move to the last topic. PCI for cardiomyopathy after revived Jason Wollmuth, and we are looking forward to the final controversial discussion from our panel and any of you attendees.
All right, thanks everybody. I know we're kind of getting late in this session. This has been a nice smattering of topics on this session, and hopefully we can end this relatively quickly and I'll get you guys off to lunch. I think this is a really important topic, and a lot of people have brought up that, hey, maybe it's controversial or this is maybe quite practice-changing. And I think it doesn't need to be, because I think we need to take the data for what it is and apply it to our practices in an appropriate manner. So here are my disclosures. So what do we know about heart failure and patients with coronary artery disease? Well, this has been shown for decades now that patients that present with acute heart failure are oftentimes undertreated and underdiagnosed. This is a finding from the Get With the Guidelines Heart Failure Registry, looking at patients who presented with new onset heart failure and were given any ischemic testing. And you can see that less than 40% of patients with new onset heart failure have any ischemic testing, and less than a quarter of those patients actually have testing on their index hospitalization. And this can be important, and this was a very interesting trial out of Canada that was published a few years ago, where they simply retrospectively looked at patients who were admitted with new onset heart failure and whether they had early invasive coronary angiography or not, and what were the outcomes between those two groups. And in the patients that had early invasive angiography, so angiography within 2 weeks of the diagnosis, there was a significant reduction in heart failure readmission, but also, and more importantly, a decrease in all-cause mortality and cardiovascular mortality. Now, in these patients, there was a significant increased rate of revascularization, either with bypass surgery or with stents. Now, did that revascularization lead to the lower mortality rates and lower heart failure admissions is not clear, but it certainly begs the question that whether revascularization early in patients with acute ischemic heart failure may have some value. So a lot of the approach to these patients has been based on the STITCH trial. So the STITCH trial was a trial performed well over a decade ago, looking at over 1,200 patients who had an LVEF less than 35%. And these patients were randomized to either optimal medical therapy or optimal medical therapy plus bypass surgery. And as many of you know, the results of this trial showed an improvement in all-cause mortality, but that improvement evolved over time. In fact, the primary outcome of all-cause mortality was not significant at 5 years and didn't become significant until 10 years. But when we look at cardiovascular death or cardiovascular hospitalization, you can see the curves start to separate somewhat early. But it's important to note that this patient population is oftentimes a very different patient population than some of the heart failure patients that we're seeing. Look at the number of patients who presented with no angina or low levels of angina, class 1 or class 2. You can see the vast majority of patients were either class 2 or less angina. Only about 5% of patients had class 3 or 4 angina. Likewise, the number of patients that had low levels of heart failure, class 1 and class 2 heart failure, was about 2/3 of the patient population. So this was a relatively stable, probably chronic coronary artery disease patient than a lot of the patients that we're dealing with clinically these days. And so one of the challenges in this field is that there's really a limited amount of data to help guide our decision making. This was an interesting meta-analysis that was published a few years ago, where they looked at 21 studies and looked at all-cause mortality and secondary outcomes of MI, revascularization, and stroke. And they looked at CABG versus medical therapy, which again showed a benefit, but also PCI versus medical therapy. There also appeared to be a benefit. And then in the trials that compared PCI to CABG, there seemed to be a favorable outcome in patients who had undergone CABG. But the problem with this trial and with a lot of our decision making is there were only 4 randomized control trials in this meta-analysis. So again, this is a relatively data-free zone. And so this brings us to the REVIVE-BESIS trial, which was published last year. This was a trial where they looked at revascularization with percutaneous intervention in patients with low EF, less than 35%. This was done in the UK at 40 centers, and over a 7-year period, 700 patients were enrolled, with a median follow-up for a PCI trial, this is quite long, of about 3.5 years. And you could see the inclusion criteria there: low EF, they had to have a ischemic jeopardy score of at least 6 or greater. But importantly, they also had to have demonstrable viability in at least 4 segments. And again, the viability testing was could be any of the above modalities. There were a few interesting exclusion criteria, which I think this informs a lot of how we approach patients, is that they excluded patients who had ACS or MI within 4 weeks or had acute decompensated heart failure or significant arrhythmias. The extent of revascularization was looked at in this trial, and this was basically done by the BESIS Jeopardy score. And they calculated the pre-Jeopardy score and the post-PCI Jeopardy score to determine a revascularization index. 100% revascularization, or a score of 1.0, would indicate complete revascularization. Optimal medical therapy was guided by heart failure specialists and mandated in the trial, with a primary outcome of death or heart failure hospitalizations and secondary outcomes of EF and functional class. Important about this trial is we have to look at the patients who were enrolled. These patients were very similar to actually the patients who were in the STITCH trial. So the number of patients who had significant angina was quite low, with only about 2% of patients having class 3 angina. The vast majority of the patients had either no angina or low levels of angina. Likewise, the functional class in the majority of the patients, over 2/3 or 3/4 of the patients, had class 1 or class 2 heart failure. So this is a very stable outpatient patient population. The baseline EF was 27%. The median number of lesions and vessels treated was 2. The median stents used was 3. And these patients had a very low incidence of revascularization with mechanical circulatory support. The revascularization index overall was 71%. And more recently, there was some data on viability that was presented at ACC, which basically showed the burden of scar in these patients was highly predictive of death and heart failure optimization, but viability was not predictive of outcome or LVEF improvement. And on the right, you can see the outcomes of the trial, where the curves really mirror each other between the OMT and the PCI group. So there are, unfortunately, a lot of still unanswered questions about this trial, and a few observations that I've had and how this impacts my practice. First off, this was a very stable population. So again, very low levels of angina, very low levels of decompensated or significant heart failure. But despite that, these patients had a very high mortality rate of about 30% at 3.5 years. These patients also, the trial also was fairly low in enrolling. So this was 7 years to get 700 patients over 40 sites. That's about 2.5 patients per year. So it begs the question, since these patients were enrolled relatively slowly and these patients had less symptoms, were patients that had higher degrees of symptom sent off to CABG or sent off to PCI? Or were patients with more complex anatomy potentially being sent for intervention? There's really no description of the stenosis severity, physiologic assessment, or the correlation with disease with either scarred segments or ischemic segments. So there's a lot of unknowns. Is the LV dysfunction explained by the coronary artery disease? These patients had low EFs, average EF of 27%, but the average number of lesions treated was only 2. So it begs the question, were these lesions really the responsible cause of the LV dysfunction? Again, these patients had a low burden of symptoms, but importantly, these patients did have an improvement in symptoms in the PCI group. The revascularization index was 71%. Is there a difference between the patients who had more complete revascularization than those that did not? Again, we don't know the answers to that. In the STITCH trial, again, we didn't see the primary outcome become positive till at 10 years. Would there be potentially a separation of groups of the curves if you followed this group out longer? Again, unknown. And then in light of the STITCH results as well as this trial, should CABG be our preferred revascularization mode in patients with ischemic cardiomyopathy and severe coronary disease? And so how has this impacted my clinical practice? Well, it certainly has, in the sense that I give a much more pause to revascularization in patients who have low EF but don't have significant symptoms. And so I look at these patients a lot more the way I look at my chronic stable angina patients, and again, offering revascularization in the patients who have the greatest symptom burden. I think those are the patients we're going to have the greatest impact on, and I think this trial really fits with the way I've treated patients with normal EF over the years. There's certainly a greater emphasis in our group in revascularization of patients with low EF who present with AMI or acute coronary syndrome or severe angina, but also patients who present with new onset heart failure, new onset LV dysfunction, or acute decompensated heart failure. And those patient populations really were not addressed either in the STITCH trial or in the BESIS-2 trial. Revascularization in this patient population is safe. I think that's an important point. And so, you know, in patients that have low EF and have multivessel disease, in my practice now, the decision making is whether they're going to have benefit from a symptom standpoint, because I know that based on this data, based on what we know with contemporary MCS, we can get these patients through complex procedures relatively safely. There was no excess death in the periprocedural period, unlike was seen in STITCH. These patients have a high mortality rate in both STITCH and as well as BESIS-2. These patients have mortality rates well over 30% at 3.5 years, which is really important for giving the patient an appropriate education and discussion about goals of care in the long run. Also with this trial, I think it's important, they did a great job at medically managing these patients. All patients were seen by heart failure specialists and really were on contemporary medical therapy. And I think involving our heart failure specialists early on, both from a medical therapy perspective, but also and importantly in helping us make decisions on revascularization is incredibly important. And then finally, I think this trial highlights the value of medical therapy, that medical therapy in this patient population is probably of the utmost importance, and it works. So thank you very much.
Jason, that was, I think you hit the nail on the head in terms of chasing symptoms. That seems to be the main driver of benefit for this patient population. And I was curious to understand, what sort of discussion do you have with your heart failure group? Because they tend to be the ones that are pushing the hardest for us to do everything we can based on STITCH, which this is a similar patient population, yet in the level of follow-up that we're able to achieve so far, we're not seeing that sort of benefit. So what sort of discussion do you have with your folks?
Well, you know, I've probably had this discussion a half dozen times since Revive came out, where I'll get a call from one of my heart failure specialists. Hey, can you look at the angiogram on this person, you know, go through the story? And a very frequent kind of answer to their question, what should we do? I'll say, well, this seems like a Revive BESIS-2 patient, and really I think our decision making is going to be driven based on their degree of symptoms. It's pretty easy to make the decision to revascularize somebody based on angina. So if somebody has class 2, 3, 4 angina, and we feel like we can make an impact on that by treating them, we tend to treat those people. The people that I think I struggle with the most now are the people that may not have angina, or they have dyspnea as their primary symptom. And again, that could be because of the ischemic cardiomyopathy, it could be because of angina, it could be because of deconditioning. There's so many things that potentially can impact it. So that's a group that I struggle with most. And so in those patients, you know, oftentimes those are the ones that I actually like to see in clinic and review the options with them. And if their revascularization options can be done in a safe and effective manner, you know, as long as the patients have the appropriate amount of understanding that this may improve their symptoms, but it's quite possible it may make no difference in their symptoms. But bigger than that, potentially probably not going to have a major impact in the mortality. Oftentimes patients can make a better informed decision. And again, I think this is a place where shared decision making really is critical.
Well, it's interesting comments, all of them. This is a very controversial topic. In my view, the decision can be simple, except we don't have the tools to make the decision. And the decision is if there is coronary artery disease that is significant and responsible for the cardiomyopathy, the patient will derive a benefit. However, we don't have a test to tell us that. So we're going out fishing and making a judgment. And let me get a step back. Let's not get discouraged about any study being negative. STITCH is a negative trial on the primary endpoint. So only a secondary analysis of some kind of an extended follow-up, which was not the primary endpoint, is a hypothesis-generating secondary analysis of a trial that is negative at the primary endpoint. So whatever that means, from a statistical point of view, with a grain of salt. So we don't have any any strong evidence really, no matter what everybody likes obviously to believe some kind of a p less than 0.5, that is the statistical reality of that result. And the problems we've seen in the REVIVE trial have a lot to do with what we heard in the previous comment. There is a lot of motivation to do something. How do we know this happened in the trial? Because it took forever to complete, and every center sent 2 to 3 patients per year in the trial. What happened to the rest of them? They went to some form of revascularization if they thought they have some level of possible benefit. And why then is that difference? Why there was somewhat more of a signal in stage? Well, because also the doctors are somewhat sane, and surgery has a major risk during procedure. There was even a mortality penalty the first few months. So if you were a doctor sending a patient that they may have a surgery versus they have just PCI, which you perceive something very safe, well, wouldn't you have a higher level of belief in you that they do have ischemic cardiomyopathy due to the CAD in the surgery patients? I wouldn't assign someone to go for surgery if I had a low level of belief versus if we're doing for PCI, maybe many doctors would say, okay, well, it's not really risky. Why don't we give it a shot? Therefore, you include in the REVIVE study a patient population that has a much lower chance for CAD responsible for CHF. And then you reap the results of that selection bias.
Yeah, one of the things that I highlighted a little bit was the data that was presented at ACC about viability, and I think that was actually really informative. And I think it actually fits fairly well with what was seen in STITCH, where the viability testing didn't seem to have any impact in prognostic outcomes. And that's similar to what we saw with the REVIVE trial. And so, you know, I know, and again, this is anecdotally, but the patients that seem to have the best recovery in LV function are the patients who are acute, who come in with new onset acute decompensated heart failure with or without an acute coronary syndrome or MI. Those are the patients that tend to have the biggest improvement in LV function. The thing that was seen both in STITCH and REVIVE was that viability didn't seem to make a big difference in determining who was going to improve and who was going to do well. And so I think that some of the authors I know suppose that, you know, chronic ischemia may lead to alterations of the myocardium that are not going to be immediately turned around by blood flow. And so I think that can be really helpful in informing how we approach these patients, that we just don't have any clear guidance that in patients with chronic coronary artery disease, long-standing ischemia, that LV function is going to magically improve. I think there's probably a very different patient population there than the patients that are more acute.
Jason, I have a question, Jason. Here's Stefan.
Where are you, Stefan?
Here.
There you are. You're moving.
Just a quick question. What about ischemia? We're talking a lot about viability, but you know, a lot of our patients are coming to the cath lab if they've had some form of nuclear tests, and it's written like appropriateness for revascularization or high risk, and then it's high because they have a high burden of ischemia. Do you factor that in versus the symptoms? Someone who is quite active but has extensive ischemia, will it sort of influence your decision for revascularization or not?
Yeah, I think I would tend to favor more revascularization in somebody who has a large burden of ischemia. I think the ones that we don't know about are the people that have that exercise nuclear stress test that shows a scar and then, you know, in their anterior wall, and then they get a PET scan that shows there's some viability there. Those are the patients who I don't know that we have an impact on. But patients who have normal functioning myocardium and have ischemia, clearly we're going to probably push towards revascularization on those patients.
All right, I hate to do this. Jason, that was a thoughtful and insightful talk and really controversial topic. But we're a little over time. And Manos, there's 2 symposiums over lunch. You want to remind us that? And then I want to thank all the panelists and speakers. This was a great session.
Yeah, thanks, Tim. And again, there are actually 3 symposia going on, 2 structures.